Welcome to the Hair Loss Show. Dr. Russell Knudsen and Dr. Vikram Jayaprakash discuss issues relating to hair loss and the medical and surgical treatment of hair loss in both men and women.
Hi everyone, and welcome to the Hair Loss Show, episode 12. My name is Dr. Vikram Jayaprakash.
I'm Dr. Russell Knudsen. Welcome.
Right, well, so today's episode, we're going to address a question that we get a lot when we see patients on a regular basis. And a lot of patients, they come to us, they've done a lot of research on the internet, they've been experiencing hair loss, they think they would like to have hair transplant surgery. So they look up online and they do a lot of research, and they see there are two techniques that there are possibilities that they can undertake, strip technique, FUT and FUE, and then a lot of them have done a lot of reading, and a lot of them come to the conclusion, actually, you know what, FUT is a bit of an older technique. You know, it was done a long time ago. A lot of the older surgeons are doing FUT. FUE is probably the more modern technique. There's a robot that does FUE as well. I like the fact that it has minimal, has no scarring, and it's going to give me great results. And so I really do think that FUT is outdated. And so when they come and see us in clinic, they come with that sort of preconception. What are your thoughts?
All right. Well, you're absolutely right. And that is the prevailing wisdom if you surf the internet, is that FUE is the way of the future. And basically, if you look at it statistically, more than 50% of the operations in the world today are being done by FUE. And if the trend line that we're seeing continues, then, FUT could die out as a surgery. Now, one of the things I think that we really want our viewers to understand today is that even though Dr. Vikram and I go to conferences year in, year out, and have been doing that for a long time, we still prefer to practice with both those techniques.
Absolutely.
And that's not necessarily true for a lot of the younger doctors coming into the field these days. They only learn to do one technique, and therefore the whole of their explanations and the way they talk about how they manage hair loss is based on the fact that they only offer one technique.
And I think it's important. I'm just going to interrupt you for a second, because the fact that you and I do both FUT and FUE is not because, chronologically, yes, we started with FUT and then developed our practice our skills in FUE, but it's not because of that. We offer both and practice both because we feel that both have their roles to play. It's not one or the other. We're not phasing out one and then practicing, upskilling in another. You and I both feel that there is a place where FUT
still
is absolutely relevant, and there is a place where FUE has a clear-cut advantage as well. So there is actually room for both.
So what we're going to try and do today is give you a balanced view about this question. So historically, when FUE started in Australia and in America, which is around about the late 90s, early 2000s, one of the marketing aspects that made a lot of us uncomfortable was this claim of no scarring. And this was a huge hook for patients. Here's an operation that wasn't going to leave an ugly scar on the back of my head. And the sad fact is that was an exaggeration of what FUE was trying to achieve. And that is that you can have minimally visible scarring, but that's not the same thing as claiming no scarring. So what I would say to all of our viewers is that you should apply a little bit of skepticism to remarks or comments that you see on certain websites that talk in absolute terms about no scarring, minimally invasive, no discomfort, right? There is no universal way that patients react to surgery that allows them to escape pain necessarily, to escape scarring necessarily. Whether we cut a hole in the back of the scalp to take out a follicular group of hairs, which is the FUE technique, or whether we cut out an ellipse of skin and sew it together, which is the strip technique, both of those are full thickness cuts of the skin.
That's right.
Both of them produce full thickness scarring.
And if you really want, if you really want to delve into it and do the mathematics of it, ironically, FUE, even though it gives you minimal scarring and it gives you a dot-like scar that is very small and it's peppered over a large area, if you add all those dots up and calculate the surface area that takes, it is probably a factor of 5 to 6 times more more surface area of scar tissue in FUE than it is in strip surgery. So the notion of it doesn't have as much scarring or as minimally there's no scarring is absolutely false. It actually has a lot more scarring. The fact that it's spread out over a larger area and in a dot-like fashion gives it the appearance of more minimal scarring.
Right. So we're going to discuss this in more detail as we go through with future videos. But basically, the thing we want to explain to patients is that if you only offer one type of surgery, then you've got to make the patient fit your operation, right? And this is something I say to young surgeons when I'm teaching them, and I teach every year, and that is that if you only offer one surgery, it's okay to learn one first, but if you only learn one surgery ever, then all the different variety of patients that comes to you, you're making them fit your operation. The alternative way to think about it is if there are two viable and useful versions of the operation and you learn to do both of them, then you could make the operation fit the patient. And in fact, one of the remarkable things that people should think about is that it's not 100% this or 100% that. It may be that both operations at different times are relevant in the same patient, which we will explain in a bit more detail. So you can use both techniques in the one patient, either sequentially, or some surgeons in the world do them even at the same time, because there are certain advantages to offering both of those techniques even in the one operation.
That's right, yes.
So we'll discuss that in a bit more detail. But I think you can get gaining the idea from listening to us that we don't believe that FUT is outdated. So let's not talk about specifically all the pluses and minuses for each technique, because we'll do that as we go along. But let's talk about where what Vikram and I are talking about really makes sense. So I'm going to grab this model of the head. Okay, so at the moment, if you look at what we drew on the back of the head, if that was your donor area, and this was the balding margin up here, in FUT, we'd be taking the hair from here,
where that
which is
central
a long way away from the balding margin. Now, if we're using FUE, because we're trying to take it in a scatter zone, it's a much larger area we're harvesting. Now, for small operations, this doesn't matter. For patients with small areas of baldness, this doesn't matter. Either technique is equally relevant.
But why is it relevant? Why are we worried about this area here? What is that? I mean, what is it about this area that is so good?
Okay, so if you have a patient that has just a little bit of recession in the front and nothing in the crown, and there's no sign of anything in the crown, then the argument is largely academic. But once you start to lose hair in this area on the back of the scalp, which is the crown area, this becomes a potential problem, because over time, not only does the area become thinner, but in most patients, the area becomes larger. And the way it becomes larger is it goes out at the side, and down at the back. Now, this is where we run into problems, because if we have a 25-year-old patient come into us that already has some thinning in the crown, we don't know how low that might dip over the next 20 years. I mean, we're currently doing some statistics on this because we have a long experience in our practice that we can track this with people. But we see it time and time again, that what we saw as the area up here as the balding margin dip down to here. Now, if your strip's down here, it's got to go a long way down there for there to be any problem. But if you're doing FUE in a patient that has crown balding as well as frontal balding, what that requires is a large number of grafts. A large number of grafts means a large number of harvests over a large area on the back of the head. And this is where we run into the risk of harvesting an area that looks okay today, but in 5 or 10 years' time has started to thin as part of as the balding margin drifts down. And that has a double negative effect. Firstly, any dot scars, remember we said there's no such thing as no scarring, any dot scars suddenly become exposed because there's no hairs around them to cover them up, which is one of the normal ways we have the advantage of the minimally visible scarring. That's the first problem. The second problem is wherever you put that graft up here, that's just balded out. So your permanent transplant became a temporary transplant. So this is a huge problem that will develop over the next 10 to 15 years in our field, because we see so many people ignoring this basic understanding of the natural progression of hair loss. And it really doesn't matter, as we know, whether our patients are taking our baldness retarding medications like finasteride or minoxidil, or they're not taking it, because there's no 100% guarantee that people will continue to take them for the rest of their life, or that they'll be 100% effective for the rest of their life. So we have to think about, when we make this plan about how we're going to use donor hair, how do we get the most benefit to the patient over the longest period of time? Because these hairs are permanently transferred, right? We don't grow new hairs to replace them. So number one, if there was no change in your balding appearance, every time you operate, you're reducing the amount of hair on the back of your head. Number two, if you are balding in the crown and coming down into your donor area, then you have a reducing donor area that's safe to use over time. And these facts just so often get overlooked or glossed over when people are doing their consultations in young men. So this is the critical factor that you have to think in a long timeline. This is what I'm seeing today. What do I think I'm going to see in 20 years' time?
And this is the problem.
What's the best thing for this patient?
And this is the problem, because even if, you've got a little bit of balding in the crown, and this is the margin, no one knows. We don't know. The patient doesn't know. I get a lot of times the patient goes, "Oh, well, I know because my father or my uncle has only lost this much hair, so I think this is where it's going to end." We don't know when it's going to end. And so if you are looking at harvesting right up to the margin, which you're going to have to do if you're trying to get a large harvest, then you run the risk of that transplant being a semi-permanent thing, because these grafts are destined to fall out in the future, whether you're taking medication, and even if you are taking medication over a long time, it still doesn't guarantee it. If these are genetically determined to fall out, they're going to fall out. So, the key is, if you've got someone, then this is the sweet spot, isn't it? This is the area where you're pretty much guaranteed that you're going to be, and that's why we call it the safe zone, because you're safe in the assumption that if you take those grafts from that area and transplant it there, that the patient's going to be with them for the rest of their lives.
Right, so there's a more safe zone and a less safe zone, is more or less what we're saying here. So the situation then lends itself, well, if I'm thinking long term in front of my patient here, what's it going to look like in 20 years' time? What's the worst thing that can happen? Well, he could lose hair down to here. He's now in his mid to late 20s. What the safest thing to do for him to give him the most long-term result is to take the hairs from what we would call the safer zone down here using a strip. So we take it out and we do what we need to do. When and if the baldness progresses over the next 10, 15, 20 years, if this margin creeps down, when he comes back at that stage, we've got a better idea of what the pattern's starting to look like, and we can, if we decide we could do another strip, or maybe we would swap to FUE, then we can just design how we're going to use the planning of the zone, of the donor area with FUE, to be in a more effective for the patient by saying, well, okay, this has drifted down a couple of centimeters here, so we can't go anywhere near that. So we have to come down here, closer to here, or down here further. And the other thing that we should remember is that we're increasingly seeing patients bald from the neck up. We call this anterograde or retrograde alopecia. And what that means is the hair margin is creeping down to the top and creeping up from the bottom. So again, there is only this smaller area in that patient that's going to have safe hairs. So I suppose the bottom line of what we're trying to say is the younger the patient that has balding crown, the more we should be worried about what the progression of the hair loss is going to do to our donor area and how that should affect or reflect our decision making as to how we take the safest hairs that are going to last the longest to give the patient the longest benefit.
And this kind of flies in the face of what people's expectations are when they come in, because quite commonly the younger men that are coming in that are losing, have got quite aggressive forms of male pattern hair loss, that are losing a lot of hair. They're the ones that have done a lot of research and go, you know what, I really want the shorter hairstyle, I really don't want to have strip. But that is that population that runs the risk of losing significantly more hair over time, and that causing more problems further down the track. So that's something to think about. But and that's certainly, you know, from a perspective of donor hair. But what we haven't talked about is the actual hair quality. And what does that do, and how does that impact? Because if you've got someone who's got actually quite fine, not very dense hair to begin with, right? If you're starting with an FUE procedure, what's going to happen? You're going to reduce the density even more, and you're going to make the donor area look see-through and even more sparse. So which you don't have that issue with strip, because with FUT you're taking 100% of the grafts from that area, you're sewing it up, you're trying to create a beautifully designed scar where the hairs go over the scar and through the scar. It's called a trichophytic closure, so that anything with a sort of grade 2 or 3 length should generally cover the scar beautifully. And you haven't ostensibly changed the density of hair at the back of the head.
It's a marginal change to the density. You remember in one of our earlier video casts, we talked about the fact that as we age, we end up with less hair on our head in total, and at the diameter of the shaft diameter decreases as well. So again, if you've got borderline low density with fine hair to start with, FUE could make it look moth-eaten as you get older. And so we've got to take a lot of factors in to consider when we try and work out what is going to give the best long-term result for the patient. So just to finish off what we're talking about today, I think the answer is that firmly Dr. Vikram and I believe that there is a good role for each of these techniques. In some patients it doesn't matter at all, but in other patients we would lean towards safety and longevity of the result by choosing a technique that is going to be in the patient's long-term interests, and not succumb to the marketing frenzy that's out there on the internet that suggests that this technique is only for old dinosaur surgeons who don't know any better, and that anybody who is doing a hair transplant today should be using the newer technique because it creates the beautiful result in every case. Short answer is there's no magic for everybody in one solution. We have to think about what's appropriate for each of our patients, ask them to consider the benefits versus the risks of which technique they're going to use. We are going to spend the next few podcasts drilling down into a bit more detail about the relative advantages and disadvantages of each technique. But everything comes at a cost. So you have to look at the relative cost-benefit analysis when you make a decision making. At the end of the day, it's the patient's decision.
Sure.
But they really, really need to make a good decision based on good information, not based on biased, marketing-driven information.
And I think that leads to a very important point. In fact, I had interesting enough, I had a patient last week who came and had a discussion. And at the end, the patient said, well, you know, I'm looking at having a hair transplant, but I'm going to see other people as well. What would you? They were asking me, what are the things I should look for in how I choose a hair restoration surgeon? And so I was thinking about that, and I listed the whole thing. And one of the things, and I think this probably comes almost to the top of the list, is I really do think if you've got someone who can give you a balanced view, you know, someone who's not trying to, as you said, make you fit into their surgical technique. If you've got someone who's able to offer you both strip or FUE and offer you them on the merits of where you lie in the spectrum of what is required, I think you're on firmer ground. Do you agree?
Surgical, I 100% agree. And surgical planning is not about what happens in 12 months' time when the grafts are grown in. Surgical planning is about what we think is going to happen 10, 15, 20 years down the track, and how do we get the best result for the patient by imagining that we're 10, 15, 20 years down the track, not working in a short time frame. So I hope that's just introduced the subject to you, to explain to you why we're going to spend some more time discussing the pros and cons for each of the techniques in the future video broadcasts. I hope you've found today helpful and informative. I want you to put a little bit of skepticism in your mind whenever you read stuff on the internet that's all promoting one idea, right? If it's just promoting one idea, there's only one solution, that's a little simplistic. It might work for them from a marketing perspective, but it's not really necessarily in every patient's interest. We think about our patients case by case. So I will say goodbye for today, and I look forward to seeing you on the next broadcast.
See you next time. Thank you very much.